So what I'm going to talk about today is implementing precision oncology in the health system. So first of all, I'd like to acknowledge the traditional custodians of the land and pay my respects to elders past, present and emerging. So before we get into a precision oncology clinic, I thought I'd take the opportunity to do a bit of implementation science education, just in case anybody's interested. So my perspective is that science is speeding up, and cancer, quite rightly, is in the lead. There's over 1/5 of the current clinical trials that are registered across the globe that are focusing on cancer. So there's so much science, but the health system is really struggling to keep pace. And these significant advances are changing the way that we need to think about managing cancer in healthcare. As David said, we know cancer clinics will look very different in 2040. So how will this happen, and how will the health system keep up to the speed of where this evidence needs to go? Implementation science can support and speed up health system change. And there are two ways in which it can do this. The first is through implementation practice. So these are the broad methods, tools, and approaches that we apply within the system to ensure that we are facilitating evidence into practice in the best way possible. And then there's implementation research. These are the ways in which we study what's happening in practice, how well these methods work, so that we can try and understand the active ingredients that lead to successful implementation. Implementation practice, everybody wants this fast. Implementation research tends to happen quite slowly. But the really good thing about this is that it helps to understand what we should replicate, how to make it generalizable, how to make it stick, and how to make it scale up. So how do we do that? We've got a few core methods that we use. The first thing is process map guided interviews. We can use this method to undertake interviews with healthcare professionals to really understand exactly what's happening right now in practice, and also identify where new interventions need to be implemented and where we want to get to. And with this, we can also use audit data to map against these processes so that we can really understand where the gaps are in practice and where we might need to focus in on for change. We can also use evidence-based approaches to identify and overcome barriers to implementation. These are where the theoretical frameworks come in, and a lot of the time, you guys don't need to know too much about the depth of that. We can take that bit forward along with you guys and really make the practical application the meaningful thing about the discussions that we have. We can also look to co-design and adapt implementation strategies according to the needs and to overcome these barriers that we've identified. We can also make sure that from the very get-go, we can support the design of interventions for implementation, so always trying to anticipate what barriers might occur to threaten the acceptability or the feasibility of an intervention before it actually reaches practice. And that early kind of work can be really important. And lastly, we can also look to understand exactly from an implementation, a service, and a patient outcomes level, what does success look like and how can we measure it? And that's really including co-designing these outcomes with healthcare professionals and with patients. And then underneath, we've got the parallel research behind the scenes to identify these active ingredients of success to enable replication at scale. So just as a brief example, a recent study that we undertook was around Lynch syndrome risk and referral. Lynch syndrome, as probably many of you know, causes 3 to 5% of colorectal cancers, with long-standing guidelines recommending Lynch syndrome tumour testing of all colorectal cancer patients. Diagnosing Lynch syndrome allows access to risk management strategies effective in preventing cancers and improving survival, and cascade testing amongst relatives. But previous research in other countries, as well as our own in Australia across 7 different states, has demonstrated substantial heterogeneity in practice. So using a variety of the methods I went through before, we were able to use these methods to improve implementation of Lynch syndrome referral practices to show effective and cost-saving outcomes. The theory-guided approach significantly increased appropriate referrals to genetics. The cost of deciding to improve implementation was about $20,000. Our approach resulted in effective strategies that improved Lynch syndrome tested and referral and would save money on an ongoing basis, and approximately over a 5-year period, $60,000. Now imagine if this was something that was scaled up on a much bigger sample of patients. If we can use these methods, we can really look to improve outcomes and to actually save cost. So the precision trial patients, Frank mentioned at the end of his talk a number of gaps that are follow the tumour sequencing process in terms of how the patients are connected back into the health system, and their precision medicine journey is undertaken in a coordinated way. So what's the next step? So we know that we've got evidence-based therapy matching and selection, but there are problems with evidence assessment, prior therapies and clinical factors. We've got clinical decision implementation, where we're looking at treatment access, treatment development, and financial toxicity, and health system implementation, where we have infrastructure support, care coordination, and expectation management. And at the moment, what we have available are the molecular tumour boards and bioinformatics to support that. So we were awarded a couple of years ago an MRFF Rapid Applied Research Translation grant to aim to integrate precision oncology into routine healthcare. And we had 3 aims, which were to co-design a precision care clinic, its implementation platform, and a suite of outcome measures, test the implementation, service, clinical, and cost effectiveness of the clinic, and develop and pilot test a scale-up model and toolkit. So the Precision Care Clinic, and you can scan here to join our launch event on the 14th of March, which is just next week, in case you're interested. So the initiative essentially involves 4 key elements. We have a specialist clinical team providing molecular multidisciplinary review and recommendations, a novel approach to care, establishing a holistic approach through a nationwide clinical network, an implementation platform harmonizing the integration of molecular genetic research into routine cancer care, and a learning health system realizing the rapid adoption of research and continuous cancer care improvement. So how have we done this? Don't get scared. This is the 6th version of this map. And there was probably a lot of others actually in between, but we basically developed this in co-design with the clinical team that we worked with, many of which are in the room today. And essentially there are 2 major streams. There's the clinic stream, which consists of medical oncology and clinical genetics, and the molecular MDT stream, both of which kind of feed into each other and out of each other to kind of direct the direction of the flow of patients. You can see on the red dotted boxes, we've got the research kind of introduction to patients and some MDT observation research that we're also doing. And this is actually how it looks in terms of its core fundamentals. So referrals can be received from anywhere in the country, usually from medical oncologists, and patients will either be discussed at a multidisciplinary team meeting, whereby peer discussion is encouraged with the oncologist who is referred. And there's also the possibility for a clinical consultation, with a summary letter being provided at the end of that particular process back to the referring clinician. And then underneath, we've got the research activities that are underway. This is the clinical team. And the mission is to provide an evidence-driven integrated advisory precision care service, enabling peer discussion and shared decision-making for timely individualized oncology and cancer genomics patient care. This is to enhance patient care quality and coordination and maximize equitable access to targeted therapies. So the research. So in terms of co-designing outcomes, this is the fundamentals of the approach. So we have the clinical intervention, which is precision medicine, and a lot of this work is undertaken mainly through the work of people like Frank and David. We have the service intervention, which is the precision care clinic, and then we have the implementation platform, which is our implementation intervention. And then at each of the three levels, we're designing specific outcomes to measure the acceptability, adoption, feasibility, and sustainability of the clinic, service outcomes in terms of uptake of clinical trial referrals, time to clinical trial referrals, time to genetic referrals, for example, and then clinical outcomes that look at patient experience, perceptions of care coordination, improved related quality of life. And of course, we're looking at a very comprehensive cost-effectiveness analysis, which is led by Bonnie Parkinson, who'll speak later on. We also have a data linkage platform that we're establishing with Xuan Lang and Frank Lin. And essentially, we are looking at a number of different types of clinical registry data. And I'm not going to go into that in too much detail because it's definitely not my expertise. But all of this feeds into the development of our digital rapid learning concept, which essentially looks to incorporate those data sources, to build knowledge, to implement it and to update it continuously to drive both the decision-making for the patients themselves, but also the decision-making in terms of how we continue to make implementation more efficient, and hopefully to eventually integrate research into healthcare more seamlessly. This is our research progress to date. I guess the main thing to say is that the clinic and the MDT has been established at Prince of Wales, and we've had around 50 patients across genetics and oncology through the system. And we're aiming to overcome a number of gaps, including through the multidisciplinary team, precision clinics. We aim to have more than just this one. We're looking at artificial intelligence, clinical informatics, integrative decision support, and then moving down along the kind of timeline, looking at novel access frameworks, industry partnerships, and public access reimbursement through our cost effectiveness analysis. So this is how you can participate. We're obviously looking to continue to understand how the clinic is working and how it can work better. And so to do that, we need to speak with clinicians and patients. And there's lots more information on our website. And there's a lot of acknowledgements, not as many as Frank's slide, I'm afraid, but maybe there will be at the end of this project. And that's it. Thanks.
Good job. Thanks. So it's opening this up for question. Ben.
So brilliant work, and I took a lot of pictures, and there is not going to come a but, because I learned everything in front of but is horse shit. What I'm asking is, we're still trying to frame precision oncology in a research box. Everything we have to do has to be proven to work, even if we're doing it with public funding in our free time. So is this maybe also a problem why people are still not believing, because we're working so hard to prove that they still have the feeling that this is not real? Do you understand what I'm getting at? So, I mean, we all, or most of us, are most probably convinced that targeted treatments work and that you have to scale them up. And then we're going great lengths to prove things that are somewhat obvious. Can you maybe comment on that a little?
I'll try. I guess from my perspective, I would say the way in which this approach, precision oncology, needs to be tested scientifically requires cooperation from the health system. Otherwise, it will never, I guess, it will never be able to demonstrate its worth. David?
I don't have, I've got one thing that I'd like to pick up on which the language that Ben used, and I think it's important to point this out, that I think one of the important elements of that clinic is integration with ongoing research and clinical trials. So in some ways, it's not about moving from research into the clinical environment. It's about tunneling a hole between the two that is legitimately part of the environment, in my view. At the moment, typically in hospitals, you have 95% of the activity occurring in standard of care outside of research. How do we incorporate a system, a learning system, which incorporates all levels of research, including monitoring itself, obviously? And I think that's a really core component of what you're setting up, isn't it?
Yeah, and I'd say even just one simple example, which doesn't even really need to be specific to precision oncology, is the way that we've aimed to engage the administrative department in the booking system, who make the bookings through the system, to introduce the notion of the clinic, the research and the consent, and then initiate the consent process. And so to have somebody who's within the system be able to initiate that for the research team is, for me, it feels like a really big milestone in terms of kind of breaking down one of those initial barriers.
I think Michael's next.
I just was trying to follow exactly how this was working. And is this a clinic that's integrated into an existing comprehensive cancer system, or is this outside it? And is it actually replacing something in a system to do it better? Or is it, if you like, providing a molecular second opinion for patients who are already in another system? Perhaps you can tell us a bit about the 50-odd patients, what sort of cancers they were, what sort of decisions were made.
I'm going to throw this to David Goldstein.
And Melita, perhaps?
And Melita, where is she? There.
A little bit of both, Michael. So it's embedded within a comprehensive cancer centre, and when there's a complex problem that goes beyond any one particular MDT, or the MDT says this needs further thought, there's within the system a clinic that can then deal with that. Clinic might be a bit of a misnomer, an advisory service, if you will. But in addition to that, it's open more widely for where there might not be quite the same degree of opportunity, and then it becomes a little bit more holistic, if you will. So it's a bit of both.
So can you give us some examples of the types of...
Yes, so for instance, some of my colleagues reached a stage where actually at the patient's request, they really said, are there really no other treatments? Is that really correct? And so we were asked to review their molecular results. We were asked to look at the treatment sequence they'd had and then provide some advice. And as you'd expect, that kind of question usually is, no, your clinician is correct. But we've also had a couple of patients where it's a rare cancer, and the ARC portal, which is another part of this system, is usually the place to go to. Then that's a little plugs, but for rare cancers. And then because very few people have that knowledge at their fingertips, a really comprehensive, here's this rare cancer, you know, it's less than 6 in a million, but this is the comprehensive understanding of biology and therapeutic opportunity. And that was done. So it's very nuanced. There's lots of examples.
Thanks.
It's an experiment, Michael. We're going through is actually partly the integration between medical oncology and germline genetics. And Melita, do you want to comment?
Yeah, so I guess from our end, from the genetic side, it's a lot about supporting the medical oncologist. So when they have a tumor profiling done, and if there are potentially germline variants, to provide that sort of that expertise and also facilitate testing and the germline assessment so that it's all happening in a more streamlined fashion in a centralized setting where I guess we have a wider access across the nation. Also, I guess from the genetic side, there are some genetic conditions where I guess the condition might mean that they might have overgrowth of some form, which is not cancer, but we might be able to exploit the pathways by using targeted therapies. And that's not sort of something that genetics clinicians would be well versed with, and where we can integrate with the medical oncologist to use their expertise of targeted therapies, but in a new setting for a rare condition where there can be a lot of disability and more morbidity associated with that.
Thanks, Melita. Chris, last question.
Thanks, Natalie, for a fascinating talk. My question was really around capability development and education. Given the huge lag we see once we do that, has this given you any insights into what you need to be doing well before the implementation in terms of education?
Yeah, so I think that's definitely going to be one component of the implementation platform that we design. I think it's trying to understand, obviously there are the centres of excellence, I think what we really need to understand, and this is something that we will do as part of this work, is where the knowledge currently is. When we received this grant a few years ago, the knowledge has probably shifted in terms of oncology expertise and understanding of precision oncology, and so we really need to try and understand what level of education is required to support people, and to make sure that the clinic is always providing some value, and that the oncologists aren't actually able to do a lot of this interpretation and management, by themselves.
Thanks, Natalie. We've got one last quick question from Ben.
A very quick one. How did you get all of your colleagues out of your center to buy in so that they will send their patients and support the informed consent? Because we struggle a lot with that.
So at the moment we've started, I would say, quite carefully, really just kind of letting trusted colleagues and colleagues who the clinical team know really well know about this service, really just to make sure that we've got the operations going pretty well before going out at the launch. So I think time will tell is probably the best answer.
Let's join in thanking Natalie for a great talk. Thank you, Natalie.